Dr. Iram from Sir Gangaram Hospital, second year DNB resident.
Dr. Devani from Sir Gangaram Hospital, final year. Dr. Devani from Gangaram Hospital,
Dr. Apollo, second.
Dr. Yogita Gangaram Hospital, second year. Dr. Vidhi Sir Gangaram Hospital, second year.
I'm Dr. Mohit Gupta, third year from Asian Hospital, Faridabad.
Your students.
I'm Dr. Neena from Medanta. Dr. Bhayavan from DNB Hospital, third year.
Dr. second year.
Dr. Pooja from Medanta, third year. Dr. Sundar, Medanta, third year.
Dr. Ritesh, Asian Hospital, Dr. Urbina. I am presenting a case of Mrs. A, 34-year female. She is married, resident of Delhi, engineer by occupation. History given by self seems reliable. She presented with complaint of fever and joint pain for 1 month. My history dates back to September 2020 when she was 30 years old. She noticed joint pain which was insidious in onset, which involved both bilateral small joints of hand and large joints in the form of wrist joint and ankle joint, which was symmetrical. Pain in small joints of hand was associated with stiffness which persisted throughout the day. Pattern of joint involvement was not remembered by patient. Joint pain was not associated with any swelling, redness, increased warmth, nodule, or any deformity or any restriction of movement. This joint pain was associated with fever, which was low grade, and it was associated with malaise and weakness. It was not associated with cough with expectoration, burning micturition, altered bowel habit, decreased appetite, or weight loss. She had a history of hair fall. There was no history of oral or nasal ulcers, photosensitivity, bluish discoloration of hands on exposure to cold, rash over face or any other part of body, redness of eyes, dryness of eyes or mouth, abnormal movement of body, loss of consciousness or any visual loss or any swelling over body, froth in urine or blood in urine. These complaints, it persisted for a month, after which she consulted a physician. She was evaluated and told to have arthritis and was advised some conservative management. With this treatment, her symptoms did not improve. So she consulted a rheumatologist in November 2020. She was evaluated and was told that her ARA and DSDNA were positive. She was told to have systemic lupus erythematosus. There was no history of protein leak in urine or and her creatinine was normal as told by patient. She was advised tablet prednisolone and tablet hydroxychloroquine and tablet mycophenolate mofetin. With this treatment, her symptoms started improving gradually. Her dose of prednisolone was gradually tapered, but she left this treatment and switched to homeopathic treatment for 6 months. While she was on this homeopathic treatment, she developed complaint of fever, which was low grade, associated with chills. It was associated with vomiting. Fever was not associated with cough with expectoration, burning micturition, or increased frequency of urine. Fever was associated with joint pain. She also noticed swelling bilateral foot, which was insidious in onset, started at ankle and gradually progressed up to knee. And this swelling, it was more pronounced. She also noticed facial puffiness, and which was more pronounced in morning hours. And so swelling was associated with foams in urine. Swelling in her bilateral limb was not associated with any redness or abdominal fullness, decreased appetite, decreased urine output, or blood in urine. So she again consulted her rheumatologist in October 2021. On evaluation, her urine report showed proteins in urine and RBCs. Her creatinine and blood pressure were normal at that time. She underwent kidney biopsy, which was uneventful. Kidney biopsy was suggestive of lupus nephritis, class 3, class 5. She was advised some injection, a name of which is not remembered by her, but she remembers that it was to be given every 2 weeks for 3 months and which had ovarian damage as a side effect. So she refused for this treatment as she was about to get married. So she was started on tablet prednisolone, tablet mycophenolate mofetil, tablet tacrolimus, and tablet hydroxychloroquine along with other symptomatic treatment. She was improving, her swelling resolved and she was symptomatically better. In December 2021, she had complaint of fever, which was low grade associated with dry cough and chest pain. She underwent evaluation which
This
shows
was December, which
2021.
say about 6 months of treatment or
2 months.
2 or 3 months of
She
treatment.
was,
In October 21, you said.
Within 2 months of treatment.
Her chest X-ray was suggestive of some patch. She was suspected to have pulmonary coughs, for which she underwent bronchoscopy and lavage. Her TB tests were negative. She was treated for pneumonia and received antibiotic for 1.5 months. During this time, her immunosuppressants were stopped except for steroid. And exact duration, she did not remember for how long her treatment was stopped, and which was later restarted sequentially. In April 2022, again she developed complaint of joint pain in bilateral lower limb associated with facial puffiness and
This
swelling.
was during the treatment.
Yeah, she was on treatment. Swelling bilateral feet which progressed up to knee and it was associated with breathlessness on exertion. On evaluation, she was told that she had high blood pressures and her urinary proteins were raised and renal functions were normal at that time. She was managed with increased dose of her prednisolone and furosemide, an antihypertensive. She was offered enrolled as she was not willing for injection for cyclophosphamide. She was offered enrollment in clinical trial of lupus nephritis in July 2022. She underwent repeat kidney biopsy in August 2022 as a prerequisite for trial, and which showed a class switch of lupus nephritis to class 4 and class 5. She was not aware of, she was enrolled in the trial and she is not aware of the name of the drug given in the clinical trial. She received some injections subcutaneously weekly for a month, then monthly. Dose is not remembered by her. Initially, while on trial, she noticed improvement in her symptoms of joint pain and lean protein started decreasing, exact values not remembered by her. While she was on this trial, she had 3 episodes of lupus, as she was told she had lupus flare in the form
So
of...
during this trial, was she taking the other medicines?
Yes,
Or
ma'am.
only the subcutaneous injection?
No, ma'am.
I
She
know
was
what
on...
this was, but was she on other medicines also?
She was on mycophenolate, tacrolimus,
And
and steroids. Along with that, this
So
medicine.
this injection plus the standard of care. Or whatever.
She had 3 episodes of lupus flare in the form of fever, joint pain, and raised blood pressure, and raised creatinine in the month of Jan, March, and July 23, for which she received a pulse dose of steroid. Her creatinine started rising gradually while she was in trial. The first raised creatinine remembered by her was 1.3 milligram per deciliter in the month of March 2023. And this trial was terminated by concerned authority in August 2023 in view of no clinically meaningful benefit. Now she is presented with complaint of joint pain for last 1 month, which involved large joints in the form of knee, ankle, elbows, which is symmetrical and it is not associated with any swelling, redness, increased warmth over this joint or any deformity. Joint pain was associated with fever, which was low grade initially, which has become high grade since last 10 days, which is associated with chills, headache, vomiting, and loose motions for the last 2 days. There is no history of cough with expectoration, shortness of breath, chest pain, burning micturition, increased frequency of urine. There is no history of altered behavior, abnormal body movement, visual disturbances, rash over body, rash over face, or swelling over body. So she was evaluated outside and told to have uncontrolled blood pressure, and her reports was suggestive of raised creatinine.
So this is the first time she has raised creatinine.
It was 1.3 during trial.
During the
in
trial, her
August
creatinine
1.
started rising. So it was more than the last creatinine remembered by her.
So this is the most recent.
Yeah,
Now she's presented with fever and
fever and joint pain.
Fever and joint
blood
pain, no
pressure,
other-
raised
and
creatinine.
headache,
And headache, vomiting.
Can you summarize this?
Yes.
Just in, always in about
34-year female diagnosed as a case of systemic lupus erythematosus in November 2020 was started on steroid hydroxychloroquine mycophenolate mofetil. She left this treatment, had a flare, underwent kidney biopsy, which was suggestive of lupus nephritis class 3, class 5, started on steroid hydroxychloroquine mycophenolate mofetil and tacrolimus. She had an episode of pneumonia for which her immunosuppressants were modified. Again, she had a flare, underwent repeat kidney biopsy, which was suggestive of class switch to class 4 and class 5. She was enrolled in a trial. After that, she has presented now with complaint of joint pain, fever for last 1 month.
we've already given most of the diagnosis.
Yeah, I know. Now, then now that you have given the diagnosis, let's start from the beginning until when she was seen and a diagnosis of SLE. Well, how do you differentiate SLE and lupus nephritis? And what are the diagnostic parameters for SLE in that patient? And what made the diagnosis of lupus nephritis?
Ma'am, her complaints that she had
Let's say the
fever,
patient-
constitutional
there was no-
symptoms and
6 months there was no SLE. She comes to a doctor and gets hematuria, proteinuria, and gets a biopsy of LN. How will you say that this is lupus nephritis?
So, ma'am, when initially she presented, she just had musculoskeletal and constitutional symptoms. There was no history of protein leakage, raised blood pressure, and when she presented again at that
In
time,
that, when you said that urine had no protein, was hematuria mentioned? Did you mention that there was no urine
so
change?
when she presented before kidney biopsy, at that time she was aware that her urine showed some blood and protein, and she had never kidney
Not this
biopsy.
one. After 6 months, when she
After the first kidney biopsy, when she
Before
underwent,
when she was SLE, at that time there was no urinary
so,
symptoms.
no ma'am, no
No
urine
urine
symptoms and
analysis.
no urine.
Something else then? In that patient, what criteria is used for the diagnosis of SLE?
When she had constitutional
So
symptoms
what are
along
the
with
criteria
musculoskeletal.
that you use for making
Fever.
the diagnosis? What are the criteria called? What are the ones?
ACR
What is it? ACR, ARA, or there is something else
Slick
now?
and another is slick.
Slick. Which is easier to do for a nephrologist? What will you, if you have a patient,
Slick.
the patient comes to you, has proliferative GL, has a biopsy which shows IgA, IgM, all those, but no C1q. How will you make a diagnosis of lupus in this patient? How will you say that it's
Slick
lupus?
is more easier if the patient present with kidney biopsy suggestive of lupus nephritis.
And one more
And
criteria.
AM.
A serological criteria, is it? So this lady, everything is being done.
Yes.
Any more questions?
See, when you have this kind of case, it's better not to give away the diagnosis every time.
Because now we have to now take you one by one, small things. So next question now I have to go back. If she refuses cyclophosphamide, how will you convince her that cyclophosphamide was the right treatment? Was cyclophosphamide the right treatment for her?
Ma'am, she already received mycophenolate for
No. The first time you said, when she was told that she has got SLE class 3, class 5, and she refused.
She was a young female at that time. We would have preferred mycophenolate.
No, not necessarily. What is the ovarian toxicity of cyclophosphamide? When is it most highest? At a 15-year-old girl or a 43-year-old lady? When do you think that cyclophosphamide has the
When
maximum?
she is young, because then ovarian reserve is more.
Exactly the opposite.
When you are ovarian reserve is more, so it will be less toxic.
So that's something you need to learn.
But she's in her 30s.
She was 13.
So you could have already convinced her that this is not the time when you are going to develop fertility issues. If you are 43 and you are still trying to conceive, then it matters. Not in 34. If you are a 15-year-old, 16, as you said, the more younger you are, the more the ovarian reserve. the less the problem with the drug. So even if let's say she is 40, how would you again convince her that yes, you can still take cyclophosphamide? Any way you can convince her? Yes, that's something you can tell her. Because we are having a case where we have not much to discuss. No? Please do. You can tell her oocyte, oocyte preservation.
Yes.
And stuck with 2-3 more questions. This is it. That is it. And the other thing what do you think was she said she took injections, no? For every 2 weeks for 3 months.
When the trial,
No, first time. The first time. We have not even gone to the trial.
she was advised
Advice. So what was that?
cyclophosphamide.
What was the
It was
regimen?
the urolupus regimen.
What is the dose of urolupus?
500 milligram.
Is it just 500 milligram or 500 milligram per meter square?
So it is 500 milligram.
So what was the initial NIH trials?
It was 0.5 to 1 gram per meter square to be given every monthly for 6 doses.
Is there a genetic or ethnic difference of cyclophosphamide toxicity?
Toxicity.
Because we have nothing here to ask now. I'm just finishing my basic questions. We are not even discussing. So, is there any trial that has shown that some drug is more effective in the induction for a certain ethnic group and some drugs are not effective?
When in arms induction trial, it was seen that mycophenolate was more effective in black and Hispanics,
For us, Indians?
and cyclophosphamide was more effective in
See,
Asians.
for Asians and here it's almost equal. That's what is ARMS full form?
Espriva lupus management study.
Maintenance of management.
Also,
Management. This was the question. What else? Kuch, let's start asking SLE questions. So this girl who came to you, and what is severe lupus nephritis biopsy wise?
then class 4,
3, 4 plus or minus 5,
5.
isn't it?
So it is diffuse proliferative.
You get so much of information. What are the factors that would have determined the prognosis see, in this patient, we have made a lot of mistakes in the treatment. First of all, we didn't convince the patient for cyclophosphamide. Then we got her into a trial, I'm aware of the name of the trial, where you were supposed to take only stable patients. This was a patient you took when the patient had a class switch. In fact, you went from 3 to 4, part 5. And the trial, yes, in August itself, I was with patients. It did not show. What was the drug that was used for what?
Anti-interleukin 17, secukinumab.
Yes, and what is the indication of secukinumab for?
And as an add-on therapy.
No, in this.
Severe.
But what is secukinumab approved for? Plaque psoriasis. It's a drug used in psoriasis. So essentially it's just an add-on therapy for standard of care. So what are the in this lady, you told us this much of the biopsy. What more information would you have loved in this biopsy before you could have prognosticated it?
The activity and the chronicity.
Can anybody say in a biopsy report, which are the classes where activity and chronicity is mentioned? Which class of? Do you
Class
give
1, class 4.
Yes. You don't get in class 1 too, no? Yes. What are
the activity is done based on 6 parameters, that is endocapillary proliferation, neutrophilic infiltration or karyohexis, crescents, cellular fibrocellular crescents, and fibrinoid necrosis, and hyaline deposits, and interstitial inflammation.
Hyaline deposits or
Hyaline or viral lesion, hyaline thrombi or viral lesions.
What are deposited? This is a very, we all will, I think Ritesh will also. In lupus, what is pathognomonic in the biopsy? Which is also considered as
Granular immune complex deposits.
what is anybody?
Antibodies.
What is anybody? What is any cell phenomenon or anybody in the biopsy? Or what are they called?
Hematoxylin
Hematoxylin bodies. So
Eosin bodies.
hematoxylin bodies. What are hematoxylin bodies? Have you ever heard? Okay, because if the examiners of my age, they will ask. This is almost pathognomonic of the biopsy.
So right now, what is she having? Finally, what is your diagnosis now?
Sir, acute on syndromic diagnosis is acute on CKD. Etiology being systemic lupus erythematosus with lupus nephritis, class 4, class 5, inadequately treated with multiple episodes of lupus flare and accelerated hypertension.
Abhidu, this is your diagnosis.
Do you think she's got a flare now?
What makes you think that she's got a flare now?
Ma'am,
In this criteria?
she has presented with fever, joint pain, along with that accelerated blood pressure, renal dysfunction.
Since the last 6 months or so, she's been having a rise in her creatinine.
Yeah, it was gradually improving.
Gradually
Increasing, rising.
It's a gradually rising creatinine. Do you think it's a relapse or it's a progression of the disease?
When it was gradually rising, that was progression of the disease, but this time it was
How
an
do you
acute rise.
differentiate?
It will be differentiated, whether it was flare or a progression of disease can be differentiated in biopsy.
When was the last biopsy done?
Last biopsy was in August 2020.
More than a year ago.
Yes.
So can the flare be differentiated with serological tests also?
Yes, ma'am. Drop in complement levels and rise in anti-DSDNA.
So what is he saying? What are they? Do you think you this time? What will you advise her? She is on tacrolimus now.
No, ma'am. Her tacrolimus has been stopped. She is on mycophenolate and steroid.
Steroids and microphone. And what are the latest parameters now?
Could the headache be part of steroids? Can the headache be caused by steroids?
Yes, ma'am.
What is it? What is the complication called as?
It
Steroid
is
induced
benign
benign.
intracranial hypertension.
Which is on steroids for
20.
Did the biopsy tell you active and chronic
Yes.
patients at the time the first time?
Patient was not aware of the activity and chronicity index. The biopsy has mentioned.
Now,
Her CBC hemoglobin was 6.6, TLC was 8.9, 8,000, and the platelet count was 2,73,000. Burn was 36.75, creatinine was 4.10 milligram per deciliter. Her urine RN showed was slightly turbid, pH 6, specific gravity 1.025, protein was 2 plus, and glucose and acetone were negative. On microscopic examination, there are 5 to 10 RBCs, 3 to 5 WBCs, and 5 to 10 epithelial cells. There was no cast. Urine protein creatinine ratio was
what was the blood in the urine? Image?
5 to 10.
No, that is RBC.
Ah.
The routine
Blood was-
examination.
When blood was
That's a big score.
It's taking how much was it? 1 plus, 2 plus, anything?
it was not mentioned.
You got that in-
Always.
You're supposed to do it yourself.
It was already available in investigation.
You could not give that in the exam. I have failed one person because they refused to do a PR for a CA prostate. We have failed once and we have written there because, see, look, theory you may know enough. But clinical examination you should, and urine dipstick has to be done well. In this we have all the information. We are just discussing clinical management of this. You cannot say, "Ki, my senior has already told me the treatment, so I will not discuss." No.
Her LFT was normal.
What if I say that blood in the urine is not from the kidneys? It's some kind of a urinary tract infection, fever, and there is some cystitis. We also say, no, I don't believe it. How will it convince us that this is?
Ma'am, we will check for dysmorphic
What
RBCs.
is dysmorphic RBCs and what is acanthocytes?
Dysmorphic RBCs change in the shape of
And acanthocytes?
Acanthocytes, when there is a spiking of the RBC's membrane.
What are Mickey Mouse cells? Have you heard of them? Any one of you? Huh? Blebs in the RBC, that makes it dysmorphic. Okay. And acanthocytes are actually broken. Schistocytes kind of a thing, dysmorphic. What percentage in the urine?
5% of acanthocytes is significant.
In
For 10
high power,
years.
40%, 40 power, 100 magnification. What magnification? Practically, theory, you can write anything. Practically, they will ask. Read up. Next one. 5% does not tell you 100% specificity or sensitivity. There is a number for that also.
Her ESR was 90 mm per hour, CRP was negative. The complement level C3 and C4 were within limit. Her dsDNA was around 200 international unit per ml. And direct the direct Coombs test was negative. PCR was done, so it was 3.62.
What do you think? Is this
What should you do? You should do a biopsy? Should you be doing a biopsy?
Ideally, we should be doing
Tell us
that.
why, tell us why not.
First, to see whether it is a flare or it is progression of towards.
What are things that tell you that there is a flare in this?
Anti-dsDNA
That's the only thing.
is the only thing, and according to report, it is not suggestive of a flare.
You have a headache, that could be part of blood pressure,
Mm.
isn't it? And increasing proteinuria can be a flare
Yes, ma'am.
or not? It was asked
But
like
that
that.
is, but increase in proteinuria can even occur in progression of a disease that can be made out by biopsy.
So you have not done a biopsy for this patient?
So how would you like to manage the patient? Now
Now
this is your
because without a biopsy, how are you going to manage this? Clinical
examination.
Past history, it was not contributory. She was her
This is completely contributory. What not contributory? For
Well,
the
she-
headache or something?
there is no history of any previous hypertension or any heart disease, tuberculosis, or any surgery in the past. She is married for 1.5 years, nulliparous. Her menstrual history is of 28-day cycle, which is regular, with bleeding for 4 to 6 days with normal flow. And
She's still having normal menses.
yes,
She never took sacrifice. Even then she did.
personal history, she is a non-vegetarian with normal appetite and normal gallbladder habit. There is no addiction. Family history, her paternal aunt, she underwent renal transplant. The patient is not aware of her basic disease, but she has expired 30 years ago. And there is no history of diabetes, hypertension, or chronic kidney disease in parents. On examination, patient was examined by me on 15th of November. She was sitting comfortably on bed, oriented to time, place, and person. Her temperature was 98.6 degree Fahrenheit. Pulse rate was 92 per minute, regular, normal volume. There was no radial or radiofemoral delay. Blood pressure was 160 by 90 mmHg in right arm supine position. Respiratory rate was 20 per minute, regular, abdominothoracic. On general examination, pallor was present. There was no interest, cyanosis, clubbing, lymphadenopathy, pedal edema, facial puffiness, any malar rash, alopecia, joint deformity, or rash in any part of the body. On systemic examination, when there was no positive finding.
She has edema, that's it. There's
No,
no sign.
edema was not present at the time of examination. Only
And
pallor.
no Cushingoid features, no steroid faces, nothing.
Nothing. No striatum, nothing.
Now, what are your concerns for treatment? Blood pressure?
Blood pressure was 160 by 90. When I examined her at the time of presentation, it was 180 by 110.
Something else you would like to see in this patient? In your examination? Which again most of you don't do. Anyone? Fundus. How does fundus help in this patient?
Ma'am, she was on steroids, so as a side effect.
Second?
Hypertensive changes.
Will papillodema make
Yeah,
a
it
difference
can
when you
because
have
of
a
raised
biopsy?
ICT. It
No, I mean,
can.
if you get a biopsy, you have some microangiopathy and all those things, that will always help you guide on the treatment. She had come with raised ICT, which is vomiting, you were saying.
Hmm.
What was causing her vomiting?
Raised blood pressure.
Anything else? As he is asking, what are your priorities in this patient that you think you need to resolve now?
Ma'am,
Is the lupus activity important now?
yes, ma'am.
Because of the DSDN.
Because of DLTN, we have to decide whether we will check
Is
the
that the
kidney
only thing
biopsy.
or something else is bothering you?
To
Organ
see the
dysfunction?
activity.
Organ dysfunction is worsening. He asked you what was the creatinine at the second map when you started?
It was normal, ma'am, at the time.
Is it 1.3, no?
It was after the kidney biopsy in March 2023. Kidney biopsy was done in August 2022. At that time, creatinine was normal.
So it was 1.3, came down to normal.
So, ma'am,
It has progressed.
It is
after
March
kidney biopsy,
2020
creatinine when kidney biopsy was done at that time, the creatinine was normal.
when was that?
In August 2022.
Two.
Yes.
And only from March 2023
March
it has been
2023 it
increasing.
started rising.
Why do you say normal? She must have given you a figure.
She told that it was always less than 1.
Obviously less than 1.
Was always less than 1.
So is this rise in creatinine is progression of chronic kidney disease or there is something acute happening?
Ma'am, she had multiple episodes of flares while she was at.
No, multiple episodes of flares is something which you are seeing which we have no evidence of. A little bit joint pain here and there or fever does not tell us.
See, that's not the way you should be presenting.
Yes.
You are making a diagnosis and presenting it. You're telling us the biopsy diagnosis. We are here to discuss the case. You should have presented clinically what's going on with the patient. Past history should have become later. What is the present reason the patient came to you? Begin with that, and then you go into the past from 2020. These are the things which have happened. And she's undergone a biopsy and she's been told she has lupus nephritis. Don't disclose in class. Even if she's told you that. You leave very little for discussion when you are giving out all the information. Now what do you discuss?
Now we are now like the clinician, isn't it? If this patient had come early, we'd like to ask anybody, can you just give us 3-4 reasons when a patient comes with renal failure and joint pains? One by one. You एक करके give one differential diagnosis, fever and joint pains and some renal dysfunction. IgA vasculitis is a chill child, ठीक है. 1. Lupus nephritis. 2, 3. Cryoglobulinemia. 4. It's a loudly. Huh? Cystic sclerosis, joint pains कितना होता है? What is common in musculoskeletal and systemic sclerosis? Raynaud's and all are more common. Next.
Rheumatoid arthritis.
Rheumatoid arthritis.
Amyloidosis.
Amyloidosis, joint pains, concerning
Actually, rheumatoid, long standing maybe, then
long
you can
term
say this
diseases,
has
you
happened.
can see it. Anyone? One of you? You notice nobody said gout. Everybody is immunologically mediated here.
Can it be osteoarthritis?
Osteoarthritis or NSAIDs.
See, the problem is when you know the diagnosis, you stop thinking. You should not know the diagnosis when you're presenting the case.
That's what your mind doesn't do. But I was thinking.
You should not. In fact, you guys should not even know the diagnosis when you take a case. This is not the way you should be presenting. You should pick up a case you have never seen in your ward. Take that case without knowing the reports. Let the other person from your unit carry the reports.
When I
That's
was
how the
told,
exams are going to happen. Na? They're not going to give you the diagnosis.
when I was told, I was thinking, क्या हो सकता है? So then you learn a little more. So now, as a clinician, you tell us what are your priorities of treatment.
I will go for a kidney biopsy and check whether it is a progression of a disease or it is a flare, and to look for the chronicity and activity index. If activity is still present, we'll continue with the immunosuppressant.
Just what is bothering her most right now? Is it the creatinine?
Sir, it is the joint pains and the
Joint
symptoms.
pains.
And the headache also.
Headache.
So what do you want to do for that? You do a kidney biopsy for headache.
Think of the headache, because he's asking that if it's my patient who's 4 years into immunosuppression with all kinds of MABs and MIBs and MOOBs, the headache will bother me the most.
Now, question right here. You're not bothered about this disease, you're bothered about something else, which is the complication of the treatment she has received for so long. She might be having an active lupus with a burnt out kidney, it's very less likely to have an accident. Right? The fever could be an infection.
It can be infected.
Fever is not always lupus now.
See what he's saying, no? In your patient, we just have a DSDNA of 200. I don't know the normal of your lab. We don't have complements. We have no other serological evidence. And and a burnt out lupus, and the only other thing was proteinuria. You didn't tell me only 3-4 RBCs, no casts. A flare has more of an immaturity and a proliferative disease because it's 3 and 4. So that's all done now. Done and dusted. We have a blood pressure which we are treating. But the headache is bothering us. Should it not bother you?
So what do you think can be the cause now?
And what should you have told us in the clinical examination? That will tell us that you are worried about that. Something
There is no
like-
neck rigidity or
Yes. Did you tell us? So, what are the common problems with headache in lupus? What are the causes of headache in lupus?
So, ma'am, it can be
बोलो 3-4 बोलो. She said we are left with this. See what is the commonest organ that is in commonest vital organ affected in SA? Kidney.
Kidney.
Next,
CNS,
CNS. More than CNS, before CNS?
heart.
Then comes brain and lungs. Lungs, pulmonary hemorrhage is very rare. We didn't even discuss the patch because we were so into 3 and 4 class first. The patch was never discussed, is it? There was a patch.
There was a patch
and then
in
they
the
all stopped 1.5 months more antibiotics given.
So you said she had tuberculosis.
No, they
She was negative for
they gave her for
tuberculosis.
TB. They gave her 1.5 months of medicine and suspended all immunosuppression. So, lupus, what are the headache in SLE? One, you said drugs. Next is disease activity. Unlikely. Third group. Infections. What are the common infections that can happen in such a patient? In our scenario.
Ma'am, tuberculosis, tubercular meningitis can lead to headache. Aseptic meningitis.
Autoimmune disease. Next. What are the common infections that you see with the immunosuppressed patient, which manifests with CNS?
Cryptococcosis.
That's the
common.
most important.
They only present with headache.
Yes, they don't have anything else.
We have other features as well, but cryptococcosis, headache, severe
It's
headaches.
just that with no neurological signs, no symptoms, and that is very common in lupus. Very common. Cryptococcal
Meningitis.
So how do you do if you're asked to do a bedside test?
Ma'am, we'll do lumbar puncture, CSF examination.
If that's CSF, if I ask you to do a bedside, something bedside, you can find out. Cryptococcus CSF, what will you do?
India stain.
And is there anything?
Cryptococcal antigen test.
How do you treat cryptococcal meningitis in a patient with SMA?
Ma'am, injection amphotericin B is given along with injection flucytosine for about A total cumulative dose is given and then
So you didn't prepare yourself, so you're not being able to. There is a long-term treatment for cryptococcal meningitis. That goes for almost 6 months
after
to
2 weeks,
1
two
year.
cytosine is stopped and amphotericin B is continued. The total dose is completed.
We don't, I mean, I'm not sure, so let's not speculate. So,
Amphotericin dose is basically given for the toxicity. Cumulative dose, you keep it at 3 grams because of renal toxicity. So she's already having a renal.
yes.
You might push her to dialysis also because of all this. So what would you want to use here? Which is less hypotoxic.
Which can be used in crypto. Azoles can be used. Azoles can be used. Yes,
For a long,
that
long
is it.
period of time.
Yes, I'll tell you as an anecdote. I have a patient. He had SLE cryptococcal meningitis. So he was going back. And when I was a student in Vellore, I got him samples of fluconazole for 3 months. He was so depressed that he committed suicide with that fluconazole dose. Completely, he took all of the tablets. So that's how I remember it has to be actually continued lifelong in cryptococcal meningitis. Think of, so other causes of headache? How do you make a diagnosis of lupus cerebritis in such a patient? So your patient the headache is settled now
It is settled as well.
because of the blood pressure. Are you happy with that things are fine?
She is symptomatically better. And
Is she still admitted in the hospital?
no, she has been discharged. When I examined her at that time, she was better.
So was she advised a biopsy or she refused a biopsy?
She was not ready for biopsy.
In this biopsy, what would you think you would have found? I mean, is there anything for this?
The chronicity.
What are the chronicity indices?
Total segmental glomerulosclerosis or tubular atrophy, interstitial fibrosis, and
by this defense.
Four of them,
fibrous
fibrous
crescent.
crescent.
So total 12 score is given. If more than 4 out of 12 is positive, then it is more likely to have worse development.
This patient, when you started treating her, you started her with steroids, tacrolimus, and mycophenolate.
Yes, ma'am.
What is this kind of treatment for?
Triple drug regimen.
Multi-target therapy.
It's called multi-target.
Multi-target.
What is the rationale of multi-target therapy?
When a Chinese study was done,
What Chinese? Do you think there is no study from India on multi-target therapy? That's the next question would have been, are you aware of trials in India published in our journals? Just the last month. In our own journal on multi-target therapy in the last 2-3 months. Is there a single Chinese study or there are other
there
studies
is a
also?
Chinese and Japanese study.
What's the rationale of using this? All 3 drugs?
When it was seen that it was better outcome than only mycophenolate and steroids.
It's better
As an add-on therapy, it was as an add-on.
Anyone of you? One, two, that is very true. Adverse effects are less. Two? Huh?
Low dose MMF was used in
No, that is because of all low. Everything is low. Tacrolimus levels are low, steroids are low, everything is low. So anything else? Loudly. Multiple site mechanisms. Then third, was the flares reduced? Relapse reduced? Any idea? Multi-target will be asked. Because today, unfortunately, me and Ritesh are talking not SLE, anything other than SLE. Besides this, do you think there are any more newer drugs which has come, which we could have offered to her?
Belimumab and
What is belimumab?
it is anti-bliss, B lymphocyte stimulating agent.
This?
B lymphocyte stimulating.
Is there any other name for it?
April,
What is the full form
a
of belimumab?
proliferating ligand, inducing ligand, a proliferating inducing.
So, Belimumab, what are the advantages? Any idea? How does that, when will you give belimumab? At induction? In place of some induction drugs? Or later?
Ma'am, it has to be given during induction and maintenance apart from the on standard of care.
How has belimumab made a difference in the result? Outcome to some लोग बोलेंगे outcome. What outcome?
Less
All this, you have to read and find out. How have these drugs made a difference? Voclosporin, what is the advantage? Clinical
advantage.
practice on voclosporin. Anyone?
It has got, whether we don't need to do drug monitoring for voclosporin
Trials.
in CNIs, and less dose of steroid is required with voclosporin, and it has
Disadvantage? Disadvantage?
it cannot be used in less GFR.
Cost. Very expensive. So these three we discussed or push anything else you want to say? And last and the last question. In this patient, when she got SLE, I mean lupus nephritis, you did a biopsy, you started therapy. How will you classify this patient? This patient attained remission or was this refractory?
She was inadequately treated because she
How
has
was
left
it?
her treatment.
She took multi-target, no? Multi-target तो बंद नहीं किया था उसने.
But when she had pneumonia, she has stopped.
That's it. After that, see the pneumonia happened, I think,
After
October she
4
started
or 5
treatment.
months.
No, so said October. And during that multi-target, December she had pneumonia. So January, again she was back to therapy. In 2023. No, 22. 22. So from there we have a year. Till exactly after a year in March, when we saw that she had a second biopsy. Before you started second pneumonia, isn't it? So how will you say in the 1 year that we had a follow-up from February 22 to March 23, in a follow-up, how would you have seen her or somebody has seen her? No, I mean your doctor saw her.
She was under care of rheumatologist.
So they have ever typed her as a complete remission, incomplete remission.
And she did not remember her proteinuria. To tell whether she is in remission, we need reduction in protein and the clinically also she told that she always had this fever and joint pain on and off while on treatment. She was never without symptoms.
Last question was rituximab ever told to her?
So she was offered this time. And initially also she was advised.
That's a why is he looking like that? Is this the right time to use rituximab?
She had more of extra renal manifestations in the form of.
Now she's got creatinine 4. What can you? That's a major manifestation. When has been retux used previously?
In refractory cases, ma'am.
So refractory when? At this time
When
of
we have already tried mycophenolate and cyclophosphamide, despite that patient is not improving, at that time we give rituximab.
So when do you decide that? In the first 3 months, when do you make
After
a
6
choice that this
months.
patient is refractory or not refractory?
Ma'am, after 6 months.
6 or 3?
After 3 months, we have to switch the treatment. If she was on mycophenolate or cyclophosphamide and there is more than 25% reduction in proteinuria, then we have to switch the drug. And after 3 months again, we have to assess if there is again no reduction in proteinuria of more than 25%. At that time, we label her as resistant and offer her rituximab.
But she was never offered. No, nobody offered.
She was offered, she was not ready for injection.
When? That time? When did she not agree to rituximab?
Initially also when she was offered cyclophosphamide, at that time also, and
So the patient was primarily treated by rheumatologist.
yes,
Even now we can get the
when
patients from
she got enrolled in the track, she consulted us. She was advised the nephrologist. She was advised to visit nephrologist, but she was not complying with it.
So when you pick up cases for discussion, don't come up with case numbers. Come up with lesser information and more
Yeah, so that we can discuss.
Exam
Now we are
all this is nothing
we're now discussing arthritis. What is the type of arthritis in lupus? Joint pain. Is it different from rheumatoid arthritis?
More erosive arthritis.
Gout we didn't discuss. I mean, that's one thing. Was azathioprine discussed before? Was azathioprine ever used in SAD?
It is used for maintenance azathioprine is
Which is better, mycophenolate or azathioprine?
When according
What are the
to
trials?
maintenance trial, mycophenolate is better than azathioprine.
In which clinical situation of maintenance where azathioprine is considered to be better than mycophenolate?
Whenever patient does not tolerate
No, not
amyloid in
lupus.
case
In a
of
clinical patient of a different
pregnancy.
category, no, that's pregnancy. But is any other disease state where azathioprine, not now because the other drug is taking over, Aza is better than mycophenolate? Anchor vasculitis. But now we are using rituximab. Isn't it? So when you say maintenance in Anchor, it is Aza, then myco. But now we are using Ritux. If this lady still wants to become pregnant, now tell us a little bit about what will you do for her pregnancy now?
At present, whatever disease is active and
What are the
creatinine
criteria?
is on the
4.
it's at 4, so she cannot be advised pregnancy at this point.
Why will you not, if required, if she still insists I want to become pregnant, what will happen to her if she becomes pregnant?
Her lupus will flare,
Lupus has to be treated, lupus may flare. Anything else?
progression of her kidney disease. Apart from that, there will be fluid loss and
Let's say creatinine was 2 and proteinuria was less than 1 gram. In lupus, what is the
if her
bench? What is
disease is
the
inactive for 6 months, then she
what
gets
is the in pregnancy? There are certain criteria we take before we advise pregnancy. At what creatinine will you advise pregnancy? Highest level.
less than 1.2.
1.2 or other criteria?
1.5.
1.5 or 1.4, 1.9? Read. Okay, one quick please. Of all these drugs, which all can she be given during pregnancy?
Steroid, hydroxychloroquine, azathioprine, CNIs.
Ritux in pregnancy.
It is used.
Next time, as you say, next time who's going to take a class? Next class. Now just tell me what are the prognostic parameters for poor outcome in lupus. In SAD, which serology tells you it's a poorer outcome? And in LN, which is the parameter which tells you it's a poorer outcome? Is there a difference?
DNA correlates with the disease activity.
Prognostic. Prognostic.
Lupus nephritis, ma'am, class
Not class, serologically.
high risk DNA titer, low complement level.
Read. Of all that you test, you see, no, SM 1, 2, 3, 4, 5, anti-ribonuclear protein and all. There is one set of tests which tells you that this is going to be poorer prognosis in LN. It's not there yet. Because we have no more questions we are asking you. Pandu, read up and some next time we will do this. We are asking you all this. Next time, as he says, please. Does treatment tell you a prognosis? You have started treatment. Is the treatment response also prognostic indicator?
Yes, if she goes into remission with treatment, it has got better outcome, and in this patient, it tells us that it is going to progress.
Okay, I was a little late, but thank you very much.